Thank you very much for the invitation, and thank you very much for such a kind introduction. It's not so clear-cut yet who should benefit from radiotherapy. But what I want to bring attention to, that unfortunately a lot of causes of death in advanced cholangiocarcinoma, not only intrahepatic cholangiocarcinoma, is local regional disease. And of the patients who unfortunately die, 80% have biliary or vascular problems as contributing to the cause of death because of the cancer invading these structures. So thinking about how to improve the local control in addition to systemic treatment is really important to help improve not only survival, but quality of life with that survival. So that's the sort of area I'm trying to improve. And for people in the room who don't know what radiation is a non-invasive way of delivering local regional treatment, which have definitely a role in the palliative setting, but could have a role in the curative setting. And unlike selective internal radiation, there is no requirement to be an inpatient or to have any invasive procedure. You lie flat on a hard couch, like having a CT scan. As John highlighted, it takes 15 years to get things going. Only now the ball is starting to rolling. With radiotherapy, we're at least 2 decades behind the systemic treatments. And we hope that molecularly characterization of and better understanding of biology will help us identify which patients would benefit from these treatments. So what I'm going to present today is some efforts we've done so far and where we probably could go next. And it's clear, we have no doubt that across the disease spectrum, local regional treatment and radiotherapy plays a role. The scheduling and the timing is still not clear. We also now know that the biliary ducts are quite sensitive to radiation, and the sort of background liver needs to be spared. So we need to use different modality of radiation depending on the disease location. So that's something to consider. So we sort of evolved the way we think about radiation. And the reason we are able to do this is because the computer science and imaging science has given us the opportunity to be able now to develop digital twins of the liver, the cancer location, and the way we sort of can deliver the radiation. So we can visualize how to deliver the radiation to the tumor and how to spare the normal tissue, the liver around it, to minimize the toxicity. And at the bottom panel, you can see on the left-hand side a proton beam therapy. So there we spare the liver, so what's gray is spared. And here is a plan with the X-ray therapy. So you can see we can model to identify how to select the best patients and the best treatment for the patient. Now, we also started to select the patients in intrahepatic and extrahepatic. In the past, all our trials were done with all the patients grouped together, and we're thinking how to sort of enhance the current systemic treatment or the current therapies options that are available, and how we can contribute to the current standard of care. But really, what's still sort of somehow challenging is that high-level evidence, and by that I mean randomized clinical trials, are still very limited. And most of the data we have is either retrospective, either single institutions, and also having unselected patients. And seeing the ABC-10 and the international efforts gives hope that in a rare cancer where you're looking for even rare situation, we might be able to understand and identify the patients who benefit from this treatment. So for me, it would be really nice to have like a biomarker. I put the test and it gives me the answer, like the medical oncologists have HER2, give this drug, you'll be fine. So we're not there yet. But just reviewing the evidence we have to date, what it shows two things. It's important to have center of excellence or which treat groups of patients with a certain conditions in rare cancers, because you can look at the patients you've treated and learn something. So in MD Anderson, in patients, even though it's a single center, in intrahepatic cholangiocarcinoma, what they were able to show that if you give a higher dose of radiation, you have a better overall survival, and better local control. So just talking about local control, 78% at 3 years versus 45% at 3 years, just giving higher dose of radiation. So that's a clue. We're still not sure how to better select the patients. There is a non-randomized phase 2 proton beam therapy study, which is a way of delivering the radiation sparing normal liver, which looked to see can we safely improve the local control in this cancer. It was combined with hepatocellular carcinoma, but what's interesting, it shows a very low rate of radiation-related toxicity, so only less than 5% of the patients had severe toxicity. So that's important to know when we combine with systemic treatments, and some of them have quite high toxicity. And also the local control, so look at the yellow bars. Yellow bars are intrahepatic cholangio. The local control at 2 years seems to be 90%. At 5 years seems to be about 70%. Just here. So it seems to be an effective treatment. If you look at the survival, the 2-year survival is about 50%. But this is before the molecular characterizations and just patients having, this is with patients having just cisgem. The trials we've done in the UK, it's mainly extrahepatic cholangiocarcinoma. We randomized to add radiotherapy after cisgem, so again, before the IO era. What I want to highlight in this study, we screened 400 patients to recruit on 83 and to randomize 69. So the attrition rate is really high. And one of the pieces of work we might need to do is to understand how we can help those 360 patients we couldn't recruit in the trial to be offering them sort of a trial. To cut a long story short, we didn't show a benefit in overall survival to the addition of radiation. Interestingly, the 2 years overall survival was 42% in the radiation arm. So that's above the sort of the expected average. There was no difference in progression-free survival. However, we showed that the radiotherapy was well tolerated, and fewer patients in the radiotherapy cohort died due to liver failure. So really the summary of this study which is 10 years of work, is that we can safely give radiotherapy, but we don't know how to select the patients who benefit from radiotherapy, and there's some more work we need to do. Possibly the molecular characterizations might help us to understand which subgroup of patients benefit. And this is, again, patients with intrahepatic cholangiocarcinoma. The gene mutations, sort of 25% were IDH1. They seem to have a median survival of 20 months after radiotherapy, so acceptable. And the other sort of data is how to help patients with low burden. So my next part of the talk is a bit random because I try to bring various information to highlight, so it might seem like I'm jumping a bit. So moving now to metastatic setting. What I'm trying to show, in patients with metastatic setting, if we treat the liver disease, which is the main burden of cancer, with radiation, there seems to be a benefit of an improvement in survival, which is sort of looks quite staggering, and it's irrespective of age or duration of the treatment. But bearing in mind this is before molecular treatments were available. We are trying to understand how to combine radiotherapy with the current sort of novel treatments coming. And rather than looking at overall survival and sort of progression-free survival, we are thinking, are there any endpoints we could consider for these patients which would enhance them living with a better quality of life? So this was a phase 2 study in patients with metastatic cancer in which one dose of radiation was given to the primary tumor. The endpoint was clinical benefit rate, in which they looked at the patients who have some benefit from the treatment rather than a sort of overall survival. And it showed that in immune treatment with SBRT, there seems to be a 30%, so 1 in 3 patients had a benefit rate with 1 dose of treatment. So should we incorporate radiotherapy and look at different endpoints which are not interfering with the, not interfering, which are complementary to the big studies that are done? Should radiotherapy done as nested study? And this is the trial John mentioned in metastatic cancer we were trying to incorporate in ABC10, which is led by Eugene Coy from MD Anderson, in which he is looking at this sort of question: adding radiotherapy is an element of the systemic treatment. Will this help to ultimately improve overall survival, as we've seen from the retrospective data I showed you earlier? And unfortunately in UK we couldn't get the funding to do this. John and previous speaker mentioned adjuvant therapy in resected disease. And this is where I'm starting to be sort of quite, that interpreting some of the data is quite challenging. So for radiotherapy, there is this US study which showed that there is a benefit of giving adjuvant radiation in a subgroup of patients. Now, this study was not randomized, but it met its primary endpoint, and it's not clear how to align this study reading the BILCAP data. We know that patients treated in BILCAP, if they had a positive margin on nodal disease, didn't do so well, regardless of the arm. But there's a lot of studies coming from various countries where radiation is added, but the standard arm is not aligned with what the current standard of care is, and this might be interesting to have a discussion, is how to, as the science and treatments are moving so forward, how to interpret the studies that are published when the control arm is not standard of care anymore. And in this particular study, it appears that radiation has a benefit in overall survival, but the reference arm was observation. So they didn't receive chemo as a BILCAP study. So is this, some people say, oh, this is the standard of care, we should give chemoradiation. I'm thinking, no, we should recruit to the new BILCAPs, I can't remember what's it called, Sapphire Impact. John, is that the right name? Yeah. And now my last sort of little nugget of where radiation could be useful in the setting of the liver transplant, and you've heard Doug talking about this sort of pathway before and the evidence that's present from the available from the Mayo Clinic, which was validated in other centers, showing that in patients with a subgroup of patients with localized cholangio who cannot be resectable, a protocol of the neoadjuvant chemoradiation and transplant would give an excellent 5-year overall survival, so a highly selected group of patients. And this is, and I don't know whether John gave me ABC 13 just to jinx it, but this is the emphatic study in which we are, it's a multi-center study in which we evaluate a proton beam therapy with a transplant in patients who have inoperable cholangiocarcinoma. There's various selection criteria we have to meet, so there are so many. Again, the attrition is really high. They have to have a background of PSC, primary sclerosing cholangitis, and be fit not only for chemotherapy, not only for radiation, but also fit for transplant and have major surgery. So this study opened this year, and we've recruited 3 patients, but it's a really complicated and so many stakeholders need to be present. It's really challenging to make sure we select the right patients, and the patients who are not eligible, they are offered the best treatment that are available to make sure this program is a success. So this is a quick summary. For intrahepatic cholangiocarcinoma, we have some evidence to support the use of radiation as local regional treatment. For extrahepatic, the data is limited, but we can incorporate radiation in various settings. We don't have any randomized control trial comparing the local regional treatments. And as I decided not to mention the list of at least 10 local regional treatments that are available. There are some small randomized control trials with local regional treatments are ongoing, but we need to have ways of interpreting data that's coming as the standard of care treatment is evolving. So in my view, we need to have better biomarkers and model to evaluate which patients would benefit from radiation, and if possible, develop and offer trials to our patients for a better outcome. Thank you.